invite Dr. DHARMESH to speak on PDR vitrectomy. Yeah, you have a taxi waiting for you?
No, I will. There's a person here.
Yeah. So good afternoon, everyone, and I would like to thank AIOS and ASRS for giving opportunity to present at this session. And I would like to talk today on PDR vitrectomies, and my financial disclosure is none. Now, PDR vitrectomy is a challenging and need a customized approach. It need to keep all the armamentarium ready. We need to do it very patiently and slowly. Aim is to prevent the iatrogenic retinal breaks or intraoperative bleeding. So usually we do on a first case of our OR day, or when we are not in a rush. That will be the case we are doing. It can become lengthy anytime. So for consideration for the surgery in the PDR, we divide 3 ways: preoperatively, intraoperative, and postoperative preparation. Preoperatively, the patient selection is very important. Expectation of the patients, we have to explain all the pros and cons. Many times after good anatomical success, still they don't have a good physiological vision. The types of diabetes in type 1 and younger patient will do early treatment. The use of anti-VEGF is very important. It's always helpful for the better dissection and bloodless surgery. Prefer to give 48 hours prior to the surgery. And we have to give after the physician fitness that once we inject, then we should not postpone or cancel the surgery, because it can give an increased tractional. So once everything is finalized, dates are fixed, then we give anti-VEGF to this patient prior to surgery. Intraoperatively, the main aim is to maintaining the hemostasis. It's very important, because all the bloodless surgeries, the better outcome as it is for the membrane dissection. The IOP control, temporary IOP control, all vitrectomy machine, just raise IOP for a few seconds, we can control the bleeding. Endodiathermy, I usually prefer endodiathermy of 27 gauge. Even in 25 gauge surgery, the 27 gauge endodiathermy is very fine. We can find each small stalk of the bleeder, and we can just do very controlled proportional diathermy. So surrounding tissue will not get damaged, especially in the around the arcade and macular areas. We can do the endolasers. Tip of the cutter, just the tip of cutter, we can just bluntly press for a few seconds and stop the bleeding. And control of systemic blood pressure during the surgery help to reduce the bleeding. Intraoperatively, the aim is to relieve the traction. So we do the careful dissection, segmentation, delamination, outside in vitrectomy. So the way the method we are doing with the newer vitrectomies, which help by cutter only, we will able to do all these steps. Tractional retinal detachment, combined RD, or a tabletop RDs. The tabletop RDs are one of the most challenging cases in the PDR surgeries. Use of triamcinolone, sir has shown just now the excellent videos. I use each and every case of PDR, and I recommend that triamcinolone should be injected for the anterior hyaloid, for the remaining vitreous section near the vitreous base, and for the hyaloid separation or the any remnant which is given tractional. ERM pilling and ILM pilling also important. Multiple techniques are used in the PDR surgeries: bimanual, bevel cutter only surgery, viscodissection, proportional reflex surgery. Gas versus oils. It's always an intraoperative decision to put the gas versus oil. Gas is preferred, but sometimes it's unavoidable, and we have to inject the oil. Post-operative close monitoring of such patient is very important. Better systemic control of diabetes and hypertension post-operatively. And if silicone oil was used, consider it for the short term, and early SOR we are doing in these patients. All armamentarium should be ready when we are planning PDR surgeries. Keep a chandelier light, finesse loop, and graphic forces, beveled cutters, and bent MVR blade. So I use the new MVR blade. We just bent a tip, and that MVR blade can be used and helpful for the very finer dissection of the membranes. Now this is the photograph will show. This is the 25 gauge bevel cutter. The port is so 47% closure, and we can go very close to the retinal surface. And this can help to dissect or just separate membrane, especially when there is a tabletop RD and there is a retinal fold. There is a high chance that we will not create a retinal break. And the only cutter with the low suction can help us to dissect the things. Now, bimanual versus unimanual is always the challenging. We can start with unimanual. At any time, we can convert to a bimanual. With the newer cutters, it is always, sometimes we are able to finish the surgery unimanually. Now, combined phaco plus vitrectomy. Now, there is both the two school of thought. Some people prefer to do combined phaco vitrectomy. Some people want a pseudophakic eye. Pseudophakic eye for diabetic vitrectomy is the best because 1 or 2 days, 2 weeks before someone has done phaco, then we will be able to remove the anterior vitreous very clearly. We can stain with triamcinolone. We prevent the anterior hyaloid proliferation and recurrent vitreous hemorrhage post-operatively. Combined phaco-vitrectomy, the cons are if we put the lens same time, sometimes gas is injected, there is some recurrent bleeding. So still there is a pros and cons for both. But if patient is from far, not able to travel, not able to come frequently, then combined surgery is preferable. So this is the surgery where we have only used the cutter. .25 gauge bevel cutter was used, and we able to separate the central tractional blend from the peripheral vitreous. Now here the most part is all this tractional band has the retinal folds underneath. And triamcinolone will help us to identify the exact plane of dissection. And now top of the membrane vitrectomy is very helpful with the 25 and 27 gauge cutter. So sometimes wherever the membrane is very stuckly adherent and not able to separate, we just keep the cutter and the port is so close that we will able to control and trim out the remaining membrane and separate it out. And once we get a good plane, we'll able to lift up whole membrane. We have to be patient till the last end of the tractional band pieces. If we are just in hurry, we can create retinal breaks. At the end, we have done ILM peeling for this patient, and as there was a retinal bands, so we have put the silicone oil for, and oil was removed after the 2 months. Now, this is one more surgery where we have separated the tabletop membrane from the surrounding, and then we have shifted it to the bimanual surgery. We have put the chandelier lights. And with the close scissors, we will just able to dissect the membrane from retina. And while dissecting, we can just take care that minimal traction should be there on retinal tissue. And if there is a bridging tissues between the two adhesion, we can cut with the cutter and separately manage each membrane. And the laser was done. Now this is another very adherent membrane. So we have used the forceps. and then changing it to the bimanual surgery after separating the membrane from the surrounding part. Sometimes the small stalks are usually a bleeder, so we take care, we slowly dissect it. In the next case, in the beginning, we started with the bad tractional RD. So the membrane was separated bimanually. The ILM peeling was done after the staining. And there was a PFCL used. There is a subretinal bands and subretinal gliotic tissue. And this was removed with the help of cutter itself. So if we not take care of this, it can give lead to recurrent retinal detachment and this. So the newer cutters are very helpful as a multifunctional tool in all these cases. So the gift of service, the best thing we can give it to the all PDR patient and the smiling faces we see. If many time it is, even the visual prognosis is not good, better to try it and give, at least they get ambulatory vision. It is better to try and do a good PDR surgery. Thank you.